Hello, we're back, and in this third and final video lecture, we'll be talking about some of the finer details of these laws and particularly how they pertain to health information management. Also have a quick comparison that I'll post on Canvas of the differences between California and Oregon law. So let's get started. Okay, we covered patient consent and so on, and advanced directives. But now we have some other things to consider. And this typically falls in the realms of the state administrative records, the administrative rules, if you will. And that's the creation and maintenance of health records. And again, typically these laws in all states talk about how all records are created. And they have language such as anybody who's admitted to the hospital must have a record created. They are to be maintained for 7 to 10 years after discharge, and so on. And the exact time frame will vary, as we'll see, from state to state. Right. And all these health records have to meet the legal standards for creation, maintenance, and disclosure. Right. So this way, if somebody subpoenas records from 5 years ago and you have a 10-year retention period in your state, you better be able to produce those records. They also cover such things as the ownership and control of the health records, including how can be used and disclosed. And a common one, as we know from, if you've read anything about HIPAA, information that's used for patient care operations, reimbursement, typically that may be disclosed. And then finally, as it says in the third bullet point, the health record is a business record. And like any business record, it has regulations involving its content, its retention, and when you can destroy them. So, what kind of requirements affect the content of the health record? Well, there's statutory laws, the federal and state statutes. There are regulatory laws, right, such as Medicare or CMS. And then there's standards by accrediting bodies such as Joint Commission. All of these influence what is kept in the record and how long it's to be kept for. The other thing is third party. Third party payers, if a physician office or hospital wants to be reimbursed by them, they have to follow their rules, and their rules cover such things as form and content of the health record. And again, the health record is owned by the organization. It's owned, say, by Peace Health Riverbend or Kaiser Sunnyside, Kaiser Permanente, and they maintain it, right? The patients have the control of it. That includes its use and disclosure. And individuals have a right to access their own information with some exceptions, right? And the HIPAA Right of Access Initiative covers such things as information blocking, electronic health information, state-specific laws. Some state laws may require disclosure without patient authorization, such as vital statistics or public health, public safety. We saw some of that during COVID. And the health record, when we use the term business record, means it's kept as a business record on all patients in the course of daily duties, daily business operations. It's complete, it's accurate, and it's timely. So we're not going back and documenting things 5, 6 years ago. It has appropriate demographic and clinical information, and it has documentation that outlines the patient treatment and progress, excuse me. And again, a lot of interest in retention. I think even though we're moving into an electronic health record age, We still reference paper records. For instance, Kaiser Permanente in the both California regions, they have warehouses that are as big as, say, 2 or 3 football fields where these old records are stored at a huge cost to the organization, right? I am told when I left Kaiser that they're looking at starting to destroy some of these records. I know in Southern California, they've already started it. I don't know what they're doing in Northern California, right? And there's different statutes of limitations on this, right? There's, again, federal, state laws, organization, operational needs. And for instance, Summit Medical Center in Oakland elected to keep records 7 to 10 years, then they were destroyed per current California law with a few exceptions. Kaiser until recently elected to keep records forever, and we use them in research. We use them for a number of different things. And again, these are subject to changes within the organization and subject to changes in federal and state law. And again, when we destroy records, we have to have a certificate of destruction and take into account all the federal and state laws, accreditation standards, and everything else. We also have to make sure that we don't have any pending or ongoing litigation. That, of course, would be a problem, obviously. And then storage capabilities and cost. And again, a lot of interest in these different types of technology. In Kaiser, Northern California region, we looked at scanning the over 7 million records that we have at our Livermore offsite storage facility and deemed it was impractical to scan them and digitize them because of the labor cost. And again, destruction, there are different ways to destroy them. One hospital I worked at, which I'd rather not name, they elected to use an incinerator, which is now illegal in California. They haven't done it for several years, but they may shred them, they may contract it out. Even if you send it out to be destroyed by somebody else, you still need a certificate of destruction that details what records were destroyed and the manner of destruction, and some sort of agreement that assures the protection of the information. And again, one of the things that we worry about with electronic health records, especially as hospitals merge and do different things, is will we have duplicate records? A lot of times when we had paper-based records, organizations would merge. They would commonly go through both sets of paper records, follow the retention guidelines per state law, destroy them. That would be it. Now it's a little bit of a different animal. So we'll see how this shakes out. Finally, we use records from medical staff credentialing. Medical staff credentialing is the process to review and give out and delineate clinical privileges. In other words, the ability to do certain things in a hospital for credentialed medical staff. And all physicians who practice at a hospital, whether they're for per diem, whether they're attending, what have you, they are credentialed. And this process is done in every hospital and also on the payer side. And related to that is the National Practitioner Data Bank that was formed by the Healthcare Quality Improvement Act of 1986. What this is a master database that tracks any physician's adverse licensing outcomes or anything else, say like if a state Bureau of Medical Licensing put a hold on their license, all of that's tracked in this national database. Speaking of credentialing, certification, licensing, people use these terms interchangeably. They're all related, but they're slightly different things. Licensure is individual permission given by a government entity to do something, to practice medicine, to drive a car, fly a plane, what have you. Certification, such as board certification, is a designation of a certain level of competence by a private organization. And healthcare organizations such as CMS have this designation that their conditions of participation are being met. Accreditation is designation of excellence by a private entity. And this could be CAHIM, which is accredited our program in health information management, Joint Commission. It's a designation of excellence above and beyond the minimal standard of licensing. So now we get into auditing. Auditing is basically looking at the records to ensure compliance with applicable laws, accreditation standards, and any third-party payer requirements. And these audits reveal any non-compliant or inconsistent practices. And they could either be internal or external. And again, internal audits are basically what it says. It's somebody internal to the organization, right? So they're reviewing records to see if there are any inconsistent or non-compliant practices. External audits were kind of what we went through at different hospitals I worked at in California, Medi-Cal field audits. So they send a Medi-Cal reviewer out from Sacramento, that you get them a conference room and they review records, in some cases upwards to a week, looking for these same inconsistent or non-compliant practices. And that's all I have for you. I hope you found this helpful. Please reach out if you have any questions about this material. We'll see you online. Bye now.